Thanks, David. That's far too kind. Gil really set this up perfectly for me. He's told the group how to risk stratify patients for treatment, and now we're going to segue into how to heal the bowel. So these are my relevant disclosures, and I think it's always good to start with a case. This is actually a real case of mine that I saw early in 2016, referred by one of my colleagues. 65-year-old Caucasian woman, retired nurse with stricturing colonic Crohn's. She was diagnosed in 2007 after presenting with aphthous stomatitis, diarrhea, erythema nodosum, and weight loss. She was treated initially with mesalamine and a tapering course of prednisone. She developed recurrent symptoms requiring a repeat course of prednisone. Azathioprine was initiated but resulted in hepatotoxicity. She was started on Adalimumab in 2012 with a good clinical response. However, her symptoms recurred requiring budesonide. She was unable to taper budesonide without developing recurrent symptoms. Her Adalimumab levels at that time at trough were 3.1 micrograms per ml, and she had no antibodies to Adalimumab. Her dosing was increased to 40 milligrams every 10 days, and we were actually able to taper her budesonide off. This is the colonoscopy findings 6 months after optimizing her dose of Adalimumab, which I'll show you here. Her level was 12 with no antibodies. Her hemoglobin and sed rate were normal. The CRP was mildly elevated. On the left, you can see a deep rake ulcer, and on the right, you can see a ulcerated stricture. So how would you manage this patient in your practice? She's asymptomatic, mild elevation of the CRP with severe ulceration endoscopically. Would you escalate her treatment only when symptoms develop or new lab abnormalities develop? Would you add methotrexate 25 milligrams sub-Q weekly? Would you change the Adalimumab to vedolizumab? Or would you refer her to colorectal surgery? So I'm going to try to convince you that we should be moving towards mucosal healing and IBD, and for this patient that I just showed, that we should actually be changing therapy based on the endoscopic appearance, not just on symptoms. Gil already showed you this slide, so that we know that there's a poor correlation in Crohn's between symptoms and endoscopic findings. The reason for this are variable. Some patients can't sense their intestinal inflammation. We also know that there's a subset of patients that have chronic symptoms despite having no inflammation endoscopically. Those are your patients with psychosocial problems, post-surgical, small intestinal bacterial overgrowth, choleratic diarrhea, superimposed IBS. So relying on symptoms alone is a big problem. This is a paper from David Binion's group at Pittsburgh. They have an inflammatory bowel disease registry linked to their electronic medical record. So what David's group did is they looked at 350 patients with Crohn's that had no symptoms and normal quality of life scores, but either had an elevated CRP at baseline or a normal CRP. They then followed them for 2 years looking at risk factors, looking at hospitalization rates. And what they found is in asymptomatic patients with an elevated CRP, the risk of hospitalization was increased compared to those without a high CRP. This represented about 20% of the population at Pitt that felt normal but had high CRP. And the most common reason for hospitalization in this group was a complication from their Crohn's, exactly as Gil was saying, asymptomatic, smoldering inflammation, fibrosis, complication resulting in a hospitalization. What are the benefits of mucosal healing? I'm going to show you a few studies that demonstrate the benefits. We know that patients that have healing have a decreased risk of relapse, a decreased need for steroids. In the step-up versus top-down study, we demonstrated there was a decreased need for anti-TNFs after anti-TNF withdrawal, decreased rates of hospitalization, and a decreased need for surgery. So this is from Accent 1, which is one of the pivotal trials looking at Infliximab for maintenance therapy. Patients in yellow are patients that had no healing at either week 10 or week 54. Blue is patients with healing at any of the 1 visits. And green, which you can't even see on the graph, is those that had healing at both week 10 and week 54. So what you can see here is patients that had no healing had much higher rates of hospitalization than those that had at least partial healing or complete healing, and those that had no healing had an increased risk of surgery at 1 year. Patients that had healing at week 10 and week 54 weren't hospitalized and did not undergo surgery. So on the far left here, I'm going to show you the follow-up of this on the far right in a second, but this is the step-up versus top-down study. So patients were treated with steroids, stepping up to azathioprine, then to infliximab. So this is the old school way we did it, as Gil mentioned. And then the top-down group received 3 doses of infliximab with azathioprine. Remember, infliximab was not maintained in this study. It was only used on demand, which is sort of the practice in Europe. The 1-year outcome here was steroid-free remission and no surgery, and they also did an endoscopic subset, which you see here. Although clinically there was no benefit of a top-down approach in this study, they did see twice the rate of mucosal healing in the top-down group compared to the step-up. In addition, if you followed these patients out for another 2 years, those that achieved mucosal healing at 2 years were much less likely to need steroids, and the group that achieved mucosal healing were less likely to go back on anti-TNF as well. So mucosal healing is an excellent prognostic factor. Gil showed this slide as well. I'm going to show it in a slightly different format. This is a Norwegian cohort that looked at 1 year post-diagnosis endoscopy and looked at the impact of mucosal healing. Mucosal healing at 1 year after diagnosis was associated with a decreased risk of colectomy. And when you look at patients with Crohn's, although at 5 years there wasn't a difference, when you extend this out to 8 years, there was a significant decrease in the rate of surgical resection in patients with Crohn's that achieved mucosal healing. So one question that we come up with is, do you have to have complete healing? Do you have to heal the entire mucosa? Gil showed you data from ACT where you could have a Mayo 0 or 1, which was as good as a Mayo 2 or 3. When Crohn's disease, this study from Schnitzler looked at patients on infliximab and looked at whether healing decreased the risk of surgical resection. In patients that had no improvement endoscopically, their rate of surgery was 38%, but those that had total or even partial healing had a much lower rate of surgery. So this study demonstrated you don't have to heal the mucosa completely, but if you at least get partial improvement, you can at least decrease the risk of surgery. So some of our challenges. So it's not as simple as maybe I make it seem. There are inconsistent definitions of mucosal healing, so I'm sure that among the faculty we all define this somewhat differently. It cannot be achieved. I'm going to show you some data that there's a significant subset of patients that we can't achieve mucosal healing in. It's unclear how much healing is needed to really improve outcomes. There really are no prospective data showing that if we treat to this target that will improve outcomes. It's unknown what incremental healing can be achieved by dose escalation. We don't really know the appropriate time interval between changes in therapy and endoscopy or other surrogates, although I think we're getting to that at around 4 to 6 months. And the role of surrogates for healing is evolving. So for RVUs, it can be very good to repeat endoscopies every 4 to 6 months, but from a patient factor, probably not the best and not cost effective. So how do we get there? How do we achieve mucosal healing? So this is looking at adalimumab. So these patients, the placebo group essentially received only adalimumab induction, then placebo maintenance. The active group received adalimumab induction and maintenance therapy, and you're looking at 12 weeks mucosal healing on the left. And you can see that continuing adalimumab achieved mucosal healing in about 25% of patients. If you follow these patients out to 1 year, it's again about 25%. So adalimumab monotherapy without adjustment, without proactive drug levels, can achieve mucosal healing in about 25%. Now let's look at SONIC. Remember, newly diagnosed patients, treatment naive, given azathioprine, infliximab, or combination therapy. You're looking at clinical remission on the left, which you can achieve in almost 60% of patients. On the far right, we're looking at mucosal healing, and you're at about 44% achieve mucosal healing with combination therapy. Again, fixed dose azathioprine. We're not doing proactive levels. We're not doing dose adjustments, so treat straight through with many of us would say is the best therapy available. You can achieve mucosal healing in less than 50% of patients. So this is some sub-analyses. So with Sonic, not every patient had a baseline endoscopy. So you're looking here at 200 patients that had a baseline endoscopy and a CRP. So what you can see here on the left is the mucosal healing in that subset. So this is a subset that had all of that available. So we knew they had lesions at baseline, and you're now up over 60% with combination therapy. If you move to the far right of this busy slide and you look at early diagnosis, this is less than 18 months. Again, getting at timing that Gil mentioned, so earlier treatment, you can now get up over 70%. So if you pick the right time, the right patient that has active disease with the best therapy, even without adjustments, we can get to mucosal healing in about 70%. So let's transition a little bit to ulcerative colitis. So this is essentially an identical trial design to Sonic, but with ulcerative colitis. And again, here you can see with combination therapy without dose adjustment, you can get clinical remission in 40% and mucosal healing in 63%. So essentially similar to Sonic. What about in clinical practice? So this was a study from Bill Sanborn at San Diego of 60 patients that had a baseline endoscopy in which they had active disease, and they were followed over time. Some important take-home messages here is you could get to mucosal healing in about 60% of patients in clinical practice. There are a couple factors predictive of mucosal healing. One was less than 26 weeks between procedures, so you make a change and you follow it up, so within 6 months. And obviously you had to do something different to get mucosal healing. So if you just looked at the finding and didn't make a change, it wasn't going to get any better. So that's sort of intuitive. The one problem with this study is you seem to think that, oh, there's all these changes that are being made in asymptomatic patients. That's not really the case. Out of the 60 patients in this study, only 7 of them were asymptomatic at the time that they made the change. Most of these patients had symptoms. So it's a little misleading to think that these are all asymptomatic people that were just pushing their therapy. So actually the patient I presented was dissimilar to the population here in this study. What about Infliximab levels? So there's a couple interesting papers that just were published in CGH. This is looking at a retrospective referral center study of ulcerative colitis patients undergoing Infliximab induction. Just over 100 patients that had paired endoscopies pre and post induction. So they were able, using conventional dosing, 5 milligrams per kilogram at week 0 to 6, they were able to achieve mucosal healing in just over 50%, which I think most of us will feel is just about right. And they did some interesting analyses. So they looked at the week 2, week 6, and week 14 Infliximab levels. At week 2, a level of around 28 predicted mucosal healing. At week 6, a level of 15 or more. And at week 14, a level of 2 or above. So as you're inducing your ulcerative colitis patient, you want to get a quick peek at a level. And if you believe in proactive adjustment like I do, you can do maybe perhaps a dose adjustment. Maybe we can improve these numbers even a little more. Another study in the same issue was an Israeli study looking at the correlation between Infliximab levels and mucosal healing. The important things to remember here is when they did their ROC curves, they found that Infliximab levels of above 5 were associated with mucosal healing. So we're always trying to think about what is our target, what target should we be shooting for. This study would suggest 5 or above is where we should be. And with Adalimumab, 7 and above was where you wanted to be. And they also found that with Infliximab, pushing the level, there seemed to be a plateau around 8. So going above 8, there wasn't much more incremental yield in mucosal healing. And with Adalimumab, it was around a level of 12. So if you're trying to take my patient and push them, she's already at 12. Pushing her above that is not going to result in further healing according to this study. So how do you know when you've achieved mucosal healing? So we're endoscopists here. Most of us are endoscopists, so we like to scope. So I would argue we should rescope them and look, especially my chief will love that. He says my RVUs are too low, so I need more endoscopies. So we should look. How do we determine endoscopically what mucosal healing is? There's a number of definitions. I would argue that right now, until we have more easier to use indices, the Frostley score is probably the best, which is absence of mucosal ulceration and no friability, you have healing. That's what I use in my clinical practice. If it doesn't look any different, it's unchanged, and then anything in between is partial improvement. And the Mayo score works quite well for UC. These evolving definitions, you're going to hear the term deep remission, which is defined as the lack of symptoms and mucosal healing. It also acknowledges that patients may have a pre-existing stricture that is not going to be impacted in most cases by treatment. So you could heal all the inflammation but still have a concurrent stricture. What other markers can we use? David Binion's group has shown us that CRP can be very helpful. This is another CGH publication from 2011, which had a number of important findings, and this was one of them, that patients that, and they actually had almost 9,000 CRP measurements in the study and over 700 patients. But what they found, that patients that had no healing, their CRP levels were 11.5, and those that had partial healing or complete healing had a level of 3. So in your patient post-induction, you're now at 2 months, 3 months, and they have a CRP that hasn't budged or remains elevated, it's unlikely that they've achieved mucosal healing. So that can be a good surrogate marker for healing. What about calprotectin? This is a smaller study looking at over 100 Crohn's patients and 40 controls. They measured multiple factors other than calprotectin, but calprotectin was the most predictive. It correlated very, very well with the CES-CD for Crohn's disease, and it was also, of all of the markers they looked at, was the only one that could really categorize endoscopic activity into no disease, mild, moderate, and severe. So it really had some discriminability. Now, I actually don't think calprotectins work that well in clinical practice. I think when they're very elevated, they tell you something, and when they're normal, they tell you something. Unfortunately, I think there's a significant gray area with calprotectin. So to conclude, what should you take from my talk? Well, I think that it's very clear that mucosal healing is associated with improved disease control, lower rates of complications and surgery. So at the very least, when you rescope a patient and they've healed, you can pat them on the back and say it's an excellent prognostic sign. That doesn't mean they should stop medications. I think that's a topic for another conference. To achieve mucosal healing, the best way to get there is to use combination therapy, in my opinion, with optimized dosing of the anti-TNF. Your goal Infliximab should be greater than 5, and your goal Adalimumab level should be greater than 7. It's unclear if pushing levels higher to get mucosal healing is effective. We know that Gil's pointed this out as well. Falling symptoms alone in IBD, particularly in Crohn's disease, is insufficient. So at least incorporate other markers into your practice. At least start following hemoglobin closely, CRP, SED rate, maybe start implementing fecal calprotectin into your practice. And when you find a patient like mine that has active disease, engage them into risk-benefit discussions of doing nothing versus adding therapy. I think that's where Corey Siegel's approach of shared decision-making is key, because this is obviously not an easy decision. And if you decide to rescope a patient to document mucosal healing, be prepared to make changes. Don't just keep watching the lesions progress. So if you're going to rescope, do something about it. Otherwise, don't rescope. So going back to my case, we actually had a discussion. Her husband and I had a discussion about best approaches, given that she was over 60 years of age and she had prior exposure to azathioprine and didn't do well. We actually added methotrexate, 25 milligrams weekly with folic acid. We continued the adalimumab at the current dose, and she will be scoped this fall to see if we have gotten incremental healing. Thank you very much.